Understanding these statistical models is key to success in New RS 337.
So the patient outcomes are represented by these charts?
Exactly.
Welcome back to the Deep Dive. Today we are shifting gears, pretty significant.
Yeah.
Usually we take this broad look at the world, but today we are zooming in with, absolute laser precision.
Mm-hmm.
If you were listening to this and you happen to be sitting in a dorm room, a library, or maybe the cafeteria at the University of Bareilly, and this is the key part, you are currently enrolled in NUR 337 Semester 5 for the academic year 2025-2026, then you need to stop what you are doing.
Right now.
Put down the highlighter, turn up the volume. This session is specifically tailored for you.
That is a very specific demographic, I'll say, but for a very, very good reason. We're essentially conducting a peer-to-peer briefing session today.
Yeah.
We're stepping into the shoes of expert biostatisticians to help break down the material for Class Session 2, Introduction to Biostatistics.
Exactly. Think of us as your study buddies who just, happen to have done all the reading twice. We are going to unpack the slide deck prepared for you. But before we get too excited about variables, standard deviations, and the Greek alphabet.
Oh, I'm sure everyone's thrilled.
And I know you're all just thrilled about that prospect.
Yeah.
We have some incredibly important housekeeping to do.
We do. And I want to be very clear about this. This isn't just the usual don't try this at home podcast disclaimer. This is genuinely crucial for your academic success in this specific course.
Okay.
This deep dive is based on the material, and this is important. Prepared by Dr. Abdul Karim Ablasi to help you put your clinical learning into practice. However, I need to make a very serious mandatory disclaimer here. This is additional material only.
Right. So listening to us chat for 40 minutes is not the same as sitting in the lecture hall, taking notes and, making eye contact with the professor.
Precisely. This does not replace physical attendance. You cannot pass this course just by listening to this deep dive while you're at the gym or driving to campus.
Okay, that's a hard line.
It has to be.
Yeah.
The nuance, the interaction, the specific academic requirements, that all happens inside the classroom. You must bring your specific questions to Dr. Abdul Karim's Q&A session. We are here to help you review and conceptually understand the material, not to replace the professor.
Message received. Go to class, folks. Do not skip.
Mm-hmm.
But for this session, let's see if we can transform the way you think about this subject. Because let's be honest, when most nursing students hear the word biostatistics, what is the visceral reaction?
Oh, panic.
It's panic. They think math. They think complex equations. They think, I joined nursing to help people, not to be a calculator.
It is a ubiquitous reaction. It's almost a rite of passage for medical and nursing students. But our mission today is to flip that script entirely.
Okay.
We want to show you that statistics isn't just a math class that you have to survive to get your degree. It is a critical nursing tool. In fact, looking at the core argument of this session, I would argue that statistics is actually a vital sign.
A vital sign, like blood pressure, heart rate, or temperature. That seems like a bit of a metaphoric stretch, doesn't it?
In a way, yes, but think about the slide that says data is everywhere in our lives. It creates a kind of flowchart of how we actually practice medicine.
Right.
It starts with gathering data. Then you apply statistics. That process gives you information. And only then can you move to making decisions and conclusions.
Okay, let's unpack that chain of events, because that seems to be the backbone of why we are here. If I'm a nurse on the floor, my gathering data is checking the patient, right?
Exactly. It's checking the monitors, reading the charts, listening to lung sounds, asking the patient how they feel. That is all raw data.
Okay.
But if you skip the statistics part, the processing part, where you analyze what that data implies relative to a norm, you're basically jumping from raw data to a decision without really understanding what the data means.
So if I see a number on a chart and I don't have the statistical context to know if that number is an outlier or an average,
Yeah.
I'm flying blind.
And in a clinical setting, flying blind is dangerous. As a nurse, the source material emphasizes that you will run into massive amounts of data daily. Every chart, every monitor, every lab result.
That's an avalanche of numbers.
It is. And you aren't just there to hold a hand. You are there to reach a conclusion based on that clinical data. Statistics is the tool you use to bridge the gap between numbers on a screen and saving a life.
The slides mention specifically that statistical techniques are used to make decisions that affect lives prevention, treatment, controlling health problems. So this isn't just abstract theory for people in lab coats.
Not at all. And consider the research context. Even if you never conduct your own research study, and many bedside nurses won't, you are going to be reading medical literature. You have to.
To keep up with best practices.
You'll be reading journals. And the planning, the conduct, and interpretation of all medical research rely entirely on statistical methodology. If you can't read the stats, you can't evaluate if a new treatment is actually better for your patient or if it's just, effective pharmaceutical marketing.
So biostatistics is essentially the language of evidence-based practice. If you don't speak the language, you can't really practice the medicine effectively.
That is the perfect way to put it. It's literacy for the modern healthcare environment. You wouldn't practice without knowing the language of anatomy, right?
Of course not.
You need to know where the liver is. Well, you shouldn't practice without the language of biostatistics, which tells you what the liver values actually mean in context.
Okay, let's unpack the landscape here. The lecture differentiates between statistics, generally, and biostatistics. I feel like for a lot of people, those are just synonyms. What's the actual distinction being drawn in the slides?
It all comes down to focus and application. General statistics is defined as the science of collecting, organizing, summarizing, analyzing, and interpreting data. It's the broad umbrella.
Right.
The example given in the slides is the population of Amman, just counting the number of people living in the country. That's general statistics.
Okay, so that's just counting things. Census Bureau stuff. It's data about stuff or people in a general sense.
Broadly, yes. It deals with data in the abstract. But biostatistics is the specific application of those exact same methods to biological and health sciences, mainly medicine and public health.
Ah.
So instead of just counting people in Raman, a biostatistician counts the number of hypertensive patients in Barami Hospital.
Or diabetic patients visiting the outpatient clinic in Barami Hospital. I see the shift now. It goes from people to patients. It goes from demographics to diagnoses.
Precisely. It's when the numbers start having a pulse. And within that umbrella of biostatistics, the slides break it down to 3 pillars or fields of application. First, you have medical statistics,
Which covers things like disease prevalence or drug efficacy. So how common is this, and does this drug work?
Right. Does this pill work better than that pill? What is the 5-year survival rate of this cancer?
That's medical statistics. It's very
Right.
clinical. Then you have health statistics.
Which is more about public health information.
Exactly. Think about tracking epidemics, vaccination rates, or sanitation levels. This is looking at the entire community as the patient. And the third one listed is vital statistics. That sounds like the government stuff again.
It is. Vital statistics is the collection of vital or important information by the government. Births, deaths, marriages, divorces.
I always wonder about that. Why does a nurse care about divorce rates? Why is that considered a vital statistic in a health context?
Because it provides the demographic backdrop against which we understand health. Social determinants of health are huge, right?
True.
Knowing the birth rate helps you plan for the number of pediatric nurses you'll need in 5 years. Knowing the death rate and the causes of death helps you allocate hospital resources. And knowing marriage and divorce rates helps sociologists and public health officials understand household structures, which impacts everything from elderly care to child welfare. It's all connected.
So medical statistics handles the treatment, health statistics handles the community spread, and vital statistics handles the life cycle events that shape the community.
That is a great way to group them.
Okay, so we know what we're talking about. We have the why and the what. Now let's talk about the fuel for this engine, the data itself. The lecture calls data the raw material.
I love that analogy. You cannot build a house without bricks, and you cannot do analysis without data. Data is the raw material. All statistical analysis is based on this collected data.
Got it.
But here's the catch. Not all bricks are the same. And if you use the wrong type of brick for the wrong part of the house, the whole thing falls down.
This is where it gets really interesting for the students in the clinic. The lecture makes a big distinction between 2 processes, counting and measuring. This seems simple, like, I learned to count in kindergarten, but I have a feeling you're going to tell me it's deeper than that.
It is absolutely fundamental to how you handle the data. If you mess this up, your analysis is worthless from the start.
Yeah.
Let's look at the source examples. First, counting.
Right.
This results in a number, a tally. The example given is counting the number of cases, like the number of hypertensive patients on a ward.
Okay, so there are 50 patients on the ward with high blood pressure. That's a count.
Correct. That is a qualitative, or what we call a discrete. concept. It tells you about prevalence. It tells you about the burden on the department. It answers the question, how many?
Right.
You can't have 50.5 patients. It's integers.
It's discrete.
Yeah.
Right. But now, look at measurement. This results from using a scale or an instrument. The example is measuring or weighing patients, specifically the actual blood pressure readings.
Exactly. So patient A has a BP of 140/90. Patient B has 180/100. That is a quantitative or continuous concept. It can have decimals. It can be a range. Do you see the difference in utility here?
I think so. Counting tells me how many sick people I have. Measuring tells me how sick they are.
Perfectly said. That's the core of it. Counting gives you volume. Measuring gives you severity and nuance. And a nurse needs to understand both.
Okay, explain that.
You need to know there are 50 patients. That's counting, so you know how many nurses to schedule for the night shift. That's resource allocation. But you need to know their specific BP readings. That's measuring. To know which patient needs immediate medication and which one is stable. That's clinical intervention.
That makes total sense. You can't treat a count, you treat a measurement.
But you manage a hospital based on counts. You need both skills. And in biostatistics, the math you do on counts is different from the math you do on measurements. You have to know which one you are holding in your hand.
Okay, so once we know we need data, and we know what kind of data it is, whether we are counting heads or measuring pressures, we have to go get it. The slides talk about primary and secondary data. I like to think of this as fresh versus frozen ingredients.
That's a really valid comparison. Let's start with primary data, the fresh stuff.
The source defines primary data as original data collected by the researcher specifically for the purpose of the study. It's pure because it hasn't been analyzed by anyone else yet.
Right. It's raw material. The pro is that it fits your specific purpose perfectly. If you want to know how nursing students at Barami feel about the cafeteria food, you go ask them. That's primary data. No one else has that data tailored to your specific question.
But the cons, it's a lot of work, I assume.
It takes enormous energy and time. You have to go out and get it. You have to design the survey, find the people, record the answers, clean the data. It is resource heavy. It's expensive.
And the slides list a few ways to get this fresh data. Surveys are a big one-personal interviews, mail, telephone.
Right. And experiments, like clinical trials, that's really the gold standard of primary data. You also have observation, either mechanical or human, focus groups, even simulations. These are all active processes where you are creating the data set from scratch. You are the miner digging the gold out of the ground.
Okay, then we have the frozen stuff. Secondary data.
Secondary data is data that already exists. Someone else collected it for a different purpose, and now you are reusing it. Ideally, these are finished products, to use your analogy.
So we're talking about journals, books, newspapers, government publications.
Exactly. Or, for a nursing context, a huge one is hospital medical records.
Oh, that's a big one. I feel like a ton of nursing research relies on that.
Huge. If you go into the archives and look at the notification of infectious diseases or the cancer registry, that is secondary data. It wasn't collected for your specific study. It was collected for patient care or for legal reasons. But you can use it to answer your own research questions.
The upside is obvious. It's fast and cheap. It's easily available. You don't have to go harass patients with surveys. The files are right there.
But the downside is what the slides call impure. Now, that doesn't mean it's bad data, but it has already been processed, or it might not answer your specific question perfectly because it wasn't designed for you.
So to recap the fresh versus frozen idea,
Yeah.
primary data is cooking a meal from scratch. You buy the vegetables, you chop them. It takes forever, but it's exactly the flavor you want. Secondary data is a frozen dinner. It's ready right now, it's cheap, but maybe you didn't want pears in your fruit cup, but you're stuck with them because that's what was in the package.
And maybe someone else already added salt to it and you don't know how much. That's the statistical treatment the slides mention. Secondary data has often already been analyzed, so you have to be really careful about bias or previous errors. You are trusting the previous cook.
Okay, moving on. We have our bricks, our data. We've collected it, either fresh or frozen. Now we need to build something with it. This brings us to the two main types of statistics. The slides divide the world into descriptive and inferential.
This is a classic divide, and it's basically the skeleton of the entire course. If you can understand this distinction, you understand the framework of the whole class.
All right, lay it on us.
Let's start with descriptive statistics. The purpose here is right in the name: to organize, describe, display, and summarize collected data.
So this is the what happened phase, just the facts.
Exactly. The tools here are the things we usually see in a report: tables, charts, graphs. just visualizing the data and using summary numbers. This is where we see the mean, the median, and the mode.
The slides show a specific example, Table 3.9, marks of students. It just lists the marks broken down by male and female. It's not predicting the future. It's just telling us exactly what happened in that specific class.
Precisely. It's a snapshot. Think of descriptive statistics as a photograph of the class. Here's exactly what is happening right now. There is no guessing. If the table says 14 students got between 30 and 40 marks, that is a fact about that specific group. It describes the sample you have in your hand. It is 100% accurate regarding the group you measured.
Okay, so descriptive is a snapshot. It's safe, it's factual, it summarizes the past. Then what in the world is inferential statistics?
Inferential statistics is the leap. The purpose is to draw conclusions about a large population based only on a small sample.
Ah, this is where the magic or the risk happens. This is the crystal ball.
It is where the science happens. It involves two main components: estimation of parameters and testing hypotheses. The ultimate goal is generalizing results.
Can we use a drug example here? Because I think that's where this really clicks for medical students.
Please, that's the best way to view it.
Okay, so if I work for a pharmaceutical company and I have a new painkiller, I test it on 100 people. That's my sample. Descriptive statistics tells me that it worked for 90 of them. Great. I can make a nice chart showing 90% success in that room.
That's your snapshot.
Right. But I don't want to sell it to just 100 people. I want to sell it to the world, to millions.
Right. You need to know if it will work for the millions of people in the general population who you didn't test. You can't test everyone. It's impossible.
So inferential statistics is the math that allows me to take that data from the 100 people and say, with some level of confidence, I believe it will work for the million.
Precisely. You are inferring the properties of the whole pie from just a single slice. Or, as the slides mention, studying the relationship between variables, like does smoking cause cancer? You can't test every smoker in the world. You test a sample, and you use inferential statistics to say, yes, this relationship likely exists for everyone.
So descriptive says, the average BP of these 10 patients in this room is a 140. Inferential says, based on these 10 patients, we are 95% sure the average BP of all patients in this city is over 135.
You've got it. One describes the known, the other predicts the unknown. One looks backward at the data you collected, the other looks forward to the population you want to treat. And that leap from the 10 to the city is where all the complex math comes in, because you have to calculate how likely it is that you are wrong.
That's terrifying and amazing at the same time. All right, before we get further, we need to open the dictionary. The slides have a section on terminologies that are essentially the vocabulary list for this course.
Absolutely.
If you don't know these, you're going to be lost in Dr. Abdul Karim's class.
These are the building blocks. If you don't know what a brick is, you can't be an architect. Let's run through them. First up, the variable.
The slide says a characteristic that takes different values in different persons, places, or things.
Examples given are weight, height. It varies. That's why it's a variable. If everyone in the world weighed exactly 50 kilograms, weight wouldn't be a variable. It would be a constant.
And in nursing, almost everything we care about is a variable.
Everything. BP, heart rate, pain score, age, response to medication, they all change from person to person.
So if it changes, it's a variable.
Yeah.
Easy enough. Next, the observation.
This one's a little nuanced. An observation isn't just looking at something. In stats, an observation is the specific event and its measurement.
The slide example is helpful here. The event is checking BP. The measurement is 120 millimeter Hg. The observation is the combination of that action and that result.
Correct. It's the data point. It's the single record in the spreadsheet. Next up, population versus sample. We touched on this, but let's define it formally because this is the most common exam mistake.
Okay, population. The entire group or event being studied. The whole pie.
Sample. A part of that population. A slice of the pie.
And sample unit.
Each individual member of that population. So if the population is all nursing students at the University of Bahraini, the sample is this specific NUR 337 class, and the sample unit is you listening right now.
Got it. And finally, the tricky one. Parameter. This one always trips me up.
This is where a lot of students struggle. A parameter is a summary value calculated from a sample that is then applied or estimated to the population.
Wait, let me get this straight. If I calculate the average height of our sample slice, that's just a statistic. But if I use that number to guess the average height of the whole pie, that guesses the parameter.
Almost. The true average height of the whole pie, the number you're trying to find, is the parameter. The number you calculated from your slice is the statistic. We use the statistic to estimate the parameter.
Ah, okay. The parameter is the holy grail. It's the real number for the whole population that we might never know for sure.
Exactly. We're always chasing the parameter.
Okay, speaking of confusing things, let's talk about the secret code.
The symbols.
Yes. The slides list a whole bunch of Greek and Latin letters. It looks like hieroglyphics if you haven't seen it before. Let's decode them so the listeners don't freak out when they see a formula on the whiteboard.
Good idea. Biostatisticians use these symbols as shorthand. Once you know them, it's actually much faster than writing out the words. Let's start with the means, the averages. If you see a $6 with a little horizontal bar over it, we call that bar, X bar.
And that represents the mean of a sample. So if I average the test scores of just the students in the front row, that's X bar.
Correct. But if you see the Greek letter mu, it looks like a U with a long tail on the front.
That represents the mean of a population.
See, context is everything. X bar is what you calculated from your small group. Mu is the theoretical true average of the whole world or the whole group you were studying. We usually use X bar to guess what mu is.
So X bar is the reality I have in my hand. Mu is the truth I'm looking for.
Poetic and 100% accurate. Next. Sigma.
Sigma looks like a little circle with a hat on it.
That is standard deviation. That tells us how spread out the data is. Is everyone getting the same grade, or are some failing and some getting 100? Sigma tells you that.
Then we have B dollars, just the lowercase letter P value.
Or probability of success.
Yeah.
Or population proportion. Basically, if you see P dollars, you should think probability or proportion. It's all about the odds of something happening.
Now, a really important distinction.
Yeah.
Little dollars versus big dollars.
Little dollars is sample size. If I surveyed 50 people, 1/5 the big dollars is population size. If there are 10,000 people in the town I'm studying, $10,000.
Getting that mixed up is a classic rookie mistake. If you use big dollar in a formula meant for little dollar, your answer will be wildly wrong.
Okay.
And finally, the math operators. A squiggly equals sign approximate.
Means almost equal to, approximately.
An equal sign with a slash through it.
Not equal to.
Yeah.
And I trust everyone knows the less than and greater than signs. And if they have a line under them, lecco argat. It just means or equal to.
So less than or equal to.
Exactly. Don't let the symbols intimidate you. They are just shorthand. Biostatisticians use them so they don't have to write the mean of the population 50 times a day. They just write $2. It's efficiency, not a secret code.
It's like how we write BP instead of blood pressure.
That's a perfect analogy.
Efficient. Speaking of biostatisticians, the slides actually have a job description for these people. What do they actually do? I think there's a misconception that they just sit in a basement with a calculator all day.
It is a rigorous, active role. They collect data scientifically, meaning they don't just ask random people random things. They plan valid research designs. They analyze data using the proper techniques so we don't get false results. But most importantly for you as nursing students,
They interpret results for decision makers.
yes. And they evaluate medical literature. This is where you intersect with them every single day. You are the decision maker at the bedside, and you are the consumer of the literature. The biostatistician is the person who ensures the information you are consuming is actually true.
So they're the gatekeepers of medical truth.
In a very real way, yes.
The slides list some real-world applications that really drive this home. It's not just research, it's everything. Let's start with physiology and anatomy.
Well, defining what is normal. Think about it. How do we know a normal pulse rate is 60 to 100 beats per minute? Did that come from a divine revelation?
No.
Biostatistics did that. Someone measured thousands and thousands of people, calculated the mean and the standard deviation, and established that range. How do we know the relationship between height and weight? Statistics. We wouldn't know what sick looked like if statistics didn't first tell us what healthy looked like.
Okay, pharmacology.
Finding the action and efficacy of a drug. You don't give a patient a pill just because you hope it works. You give it because statistics proved it works better than a sugar pill, a placebo. Every single dosage recommendation, every side effect warning comes from biostatistics.
Medicine.
Comparing two treatment methods, treatment A versus placebo, or treatment A versus treatment B. Which one is better? The numbers decide, not a doctor's gut feeling. This is the very heart of evidence-based practice. Without this, modern medicine is just guesswork.
And public health.
Testing vaccine safety. The usefulness of health interventions. This is health statistics in action. When the Ministry of Health decides to launch a new public awareness program, it's because the biostats showed it would save lives. It helps them decide where to build new hospitals and where to send vaccine supplies.
It really is everywhere. You can't escape it.
And you shouldn't want to. It is the safety net that ensures we aren't just guessing with people's lives.
So we've covered the why, the definitions, the difference between counting and measuring, the types of data, the symbols, the applications. It's a lot, but it's the foundation.
Yeah.
If a student walks away from this deep dive with just one thought, what should it be?
That data is the raw material of their future career. Whether they are counting hypertensive patients in a ward or measuring a single patient's blood pressure, they are generating the data that drives all of healthcare.
Wow.
They aren't just passive observers, they are the source of the data. Every single time you write in a patient's chart, you are contributing to the biostatistical universe.
That's a powerful thought. You are the bricklayer of the House of Medicine. And a final reminder from me, attend the Q&A. Dr. Abdulkarim Ablasi is the source of all this wisdom. Go ask him the hard questions about parameters versus statistics.
And check the references listed in the slides. Pollitt and Beck, Monroe, Huck. These are the Bibles of nursing research. If you find yourself confused, open the book.
This has been a deep dive into Class Session 2. Good luck to the NUR 337 cohort. You've got this.
Study hard.
See you next time.